GERD and PUD, peptic ulcer disease. Before we get started, let's clarify some terminology. Gastritis refers to stomach irritation, and GERD refers to esophagus irritation, basically heartburn. GERD stands for gastroesophageal reflux, fancy words for heartburn or acid reflux, where stomach acids burn away at the esophagus. And PUD, as mentioned before, is peptic ulcer disease. We have open sores and ulcers inside the lining of the stomach or the intestine. So for gastric ulcer, we have a stomach ulcer. And a duodenal ulcer or a duodenal ulcer, we have small intestine ulcer. So let's break down GERD first. The pathophysiology is pretty simple. We see heartburn from acid reflux. So just let the name help you here. Gastro means stomach, esophageal means esophagus, and reflux is acid, and disease just means disease. Again, this is from stomach acids being kicked up from the stomach into the esophagus, causing pain and injury, leading to inflammation and even cancer from all the erosion. This is what's called Barrett's esophagus, if the chronic acid reflux is not treated. Now, in terms of signs and symptoms, we get a burning epigastric pain known as dyspepsia, or basically heartburn. Now, it's critical to know that this heartburn gets worse while lying down. So write that down. Lying down makes the pain worse. Now, for causes and education, we have a weak or damaged LES, that lower esophageal sphincter, which is the muscle that closes the opening between the stomach and esophagus. So we must avoid anything that can cause irritation or more acid that can further weaken this LES. So the most tested key points that love to come up on Select All That Apply questions. Write this down. Things to avoid when you're eating. So foods that cause acid production. Anything fried. Now trust me, we see this a lot on multiple different question banks. So fries, fried chicken, and even fatty foods. So a low-fat diet is best. And citrus foods can cause acidity, and dairy like milk and cheese can also cause more acid. Now, a really interesting one is chocolate as well as peppermint and spearmint. So write these down. These can cause a relaxation inside the esophageal sphincter, leading to worsening heartburn. Now write that down. We saw it on 2 different question banks. And now for the no-no list. No caffeine, including coffee, no cigarettes or tobacco, and no alcohol in excess. Remember, on the NCLEX and exams, caffeine, smoking, and alcohol are never good. Just save it for after the NCLEX here. Okay, now for regurgitation, that can happen when lying down. So we must teach patients to avoid eating before laying down. The big key term here is before. So teach patients the 3-hour window. After eating, they must sit up after meals for at least 3 hours. And we elevate the head of the bed at night and eat small meals. So when you get a client with GERD who states they will have a bedtime snack 1 hour before bed, this is completely wrong here. Major acid reflux is coming. We need to re-educate that client to have the snack and then wait 3 hours before going to bed. So Hesse mentions, which advice would the nurse give to a patient experiencing heartburn after meals? Identify and avoid causative foods. And Saunders mentions, when teaching a client with gastroesophageal reflux disease, GERD, about substances to avoid, which items should the nurse include on the list? Select all that apply. So coffee, obviously. Chocolate and peppermint, those 2 are the tricky ones, right? So hopefully you wrote them down, as well as fried chicken. So again, write down that list. Now, in terms of risk factors, this includes stress and obesity, which is technically a BMI over 30. You see, more pressure on the gastric area can cause dilation of this lower esophageal sphincter, the LES, allowing more acid to come from the stomach and burn the esophagus. So we must teach clients to lose weight. And another cause is a hiatal hernia, which we cover in another video. But it's basically the upper part of the stomach bulges through an opening in the diaphragm, And now acid gets stuck inside this protruding part of the stomach here, causing acid reflux. Now, in terms of pharmacology, the goal here is to reduce acid and prevent this burn. So let's play our next segment from our pharmacology master course. Now, antacids are used for fast, immediate relief. So think anti-mixing for antacids. They're never to be taken with other meds. Probably the biggest test topic I can cover right here. Now, it works by immediately neutralizing stomach acid, but the bad news here is that it doesn't last long. So the acronym we use is SCAM, like you kind of got scammed from the short duration of the med. So S for sodium bicarbonate, brand name is Alka-Seltzer. C is for calcium carbonate, brand name Tums and Rolaids. A for aluminum hydroxide, and M for magnesium hydroxide. Brand name is Milk Magnesia. Now that's also a laxative as well as an antacid here. Now guys, the big side effects can vary on the type of antacid. So for aluminum or calcium, they can constrict and cause constipation. And magnesium can mellow out the GI tract, causing diarrhea. Now on the HESI, there was an exam question about magnesium hydroxide. And it said it can upset the stomach and cause liquid bowel movements. So write that one down, guys. Now the key point here and the memory trick, again, really stressing it here, antacids are anti-mixing with other meds. Basically blocks the absorption of a lot of medication. So the key point, never taken with other meds. Always 1 hour before or 1 hour after other meds. And guys, it's not for heart failure patients. Nothing OTC are for heart failure patients or over-the-counter drugs. All these things contain sodium, which swells the body. Now, next up is our long-lasting relief, the H2 blockers, histamine 2 receptor antagonist. Fancy words for turns down the volume of acid production. Now, these end in tidine. So, ranitidine, brand name is Zantac, and famotidine, brand name is Pepcid. Now, the key point is we take 30 minutes before the meals. So think tidine, you take 30 minutes before you go to dine with tidines. So guys, it's given for GERD and ulcers, both duodenal and gastric. And it works by reducing those gastric secretions by blocking H2 receptors in the stomach. And a big patient education here. We do not overeat, no stress, or basically stress reduction, no smoking, and no NSAIDs, which leads to GI bleeding. Now for the famous PPIs, the proton pump inhibitors, ending in prazole, like omeprazole, brand name Prilosec, or esomeprazole, brand name Nexium, and the famous pantoprazole, brand name Protonix. Now the key points are the 3 P's of prazoles. P for prevents holes. So guys, a key word here is stress ulcer prophylaxis. P for porous bones. So we get regular bone density tests. And P for possible C. diff, or Clostridium difficile infection. So guys, the indication here is for heartburn and GERD, but mainly it's used for ulcer prophylaxis, especially in the hospital due to the hospital-related stress. So guys, nearly everyone in med-surg usually gets put on a PPI. So when a patient asks, why am I on this med since I usually don't take this at home? Guys, the key word here is it helps prevent the development of an ulcer due to the stress of surgery or hospital stays. Now, it works by reducing the gastric acid by inhibiting the proton pump in the parietal cells of the stomach. And once again, for reinforcement here, long-term side effects. P for porous bones. Again, guys, write this down. Regular bone density test. It increases the risk for osteoporosis with long-term use, increasing the risk for fractures on the spine, wrist, and hip. So guys, always take calcium and vitamin D. And lastly, P for possible C. diff infections, since it suppresses the normal HCl in the stomach, which would normally control the intestinal bacteria. And the last key point is we take 30 minutes before meals, which goes for H2 blockers as well as these PPIs. Okay, now for procedures. What if the GERD persists even after diet change and pharmacology? It could mean that the lower esophageal sphincter is not closing all the way, or it might be loose. So we can always send a scope down into the stomach to check this out. This is called an upper gastrointestinal endoscopy. So remember, the word scopy means scope, a small tube with a camera. Now Hesse mentions a patient with persistent gastroesophageal reflux disease despite diet change and proton pump inhibitor. Which test does the nurse anticipate being performed to determine the LES competency? Upper gastrointestinal endoscopy. Now, if ulcers are suspected, then we can go a little bit deeper with an EGD, an esophagogastroduodenoscopy. Woo, that was a big one. So to break down the word real quick, esophagus, gastro means stomach, duodenal, or basically duodenal, is a small intestine, and endoscopy means a scope, a little video camera to check all those areas out. Now, a big complication with any scope inserted into the GI tract is a deadly perforation of the bowels. Fancy words for puncturing a hole, or basically popping a hole inside the bowel here. This can lead to deadly peritonitis and sepsis infection inside the blood, which can kill the patient. So write this down. Peritonitis is priority. We must report these findings to the HCP. So a fever over 100.3, rebound tenderness, as well as a rigid board-like abdomen. Those three love to go up on the NCLEX and nursing exams. But we'll also see increased pain and tenderness, restlessness, and a fast heart rate and respiratory rate. Again, these keywords are priority, but really the most important here is fever. Even the slight increase is bad, because this is an early sign of the deadly sepsis infection post-procedure. Now, don't let the NCLEX trick you here. Blood pressure changes are normal after the procedure due to sedation used during the procedure. And a gag reflex that is slow to return is also normal and to be expected, since a topical analgesic is used to numb the throat to help the tube pass. And speaking of gag reflex returning, we must make sure to keep the client NPO, nothing per oral, so no eating, no drinking until the gag reflex returns. Huge airway risk for aspiration and choking. So Hesse mentions, which action by the unlicensed assistive personnel, the UAP, in the post-procedure, key term, of a patient who is returning from an upper gastrointestinal endoscopy would prompt the nurse to intervene immediately. So you have to think airway. Offering ice chips and water. Yes, the big priority here is NPO, major airway risk. Now, in terms of surgeries, this is our last line therapy if diet and drugs don't work. Not really common on the NCLEX, but it may show up on your nursing exams. Our main goal here is to tighten up that LES, the lower esophageal sphincter, the opening between the stomach and the esophagus here, which stops the acid from backing up. So we can use a Stretta procedure that delivers radio frequency energy through electrodes to tighten up that LES. Or we can do a fundoplication, where we wrap the upper curve of the stomach, called the fundus, around the esophagus and sew it shut. This helps tighten the esophagus sphincter, but again, it's not really tested on the boards. So you don't really have fun with a fundoplication. Now for PUD, the peptic ulcer disease. The pathophysiology is pretty simple. We have open sores or holes inside the esophagus, stomach, or duodenum, also called the duodenum. It happens when the gastric acids erode the gastric lining, creating an open hole, or basically an open sore. So signs and symptoms, write these down. We have dyspepsia, or basically burning pain like epigastric pain that radiates to the back. And in a gastric ulcer inside the stomach, we see pain that increases with food. Write that down. The NCLEX will expect you to know when the pain comes with a gastric ulcer. So it's with food, 30 to 60 minutes after meals. And weight loss is typical because when you eat food with pain, you kind of don't want to eat food anymore. And vomiting blood, that hematemesis, is very common. Now, switching gears to a duodenal ulcer or a duodenal ulcer inside the intestines. Very, very different here because pain is decreased with food. 2 to 3 hours after meals is when the pain comes. And it's worse at night. So we see weight gain as well as blood in stool called melena. So write it down. It looks like dark, tarry stool. So the memory trick we use is for gastric ulcer, we have gut pain with food. And for duodenal ulcers, we don't have pain with food. So just think of the double G's and the double D's. So write that down and know it for your exam. Now, in terms of the complications, what's the worst thing that can happen with a hole inside the intestines? Well, perforation and peritonitis leading to sepsis here. Just like we explain in all the GI lectures, peritonitis is the most deadly because it can lead to septic shock. Just think about all these gastric juices going out of the bowel and into the body, now causing a major infection. So once again, report to the HCP these top 3. A fever over 100.3, rebound tenderness, and rigid or board-like abdomen, as well as increased pain and tenderness, restlessness, and a fast heart rate or respiratory rate. Since all these are early indications of deadly perforation of a bowel, client will become very septic very quickly and die. So we must report any low-grade fever immediately. Saunders mentions, a client with a peptic ulcer, which assessment finding would most likely indicate a perforation of the ulcer? A rigid board-like abdomen. Yes, that was our number 3 there. A rigid board-like abdomen could mean peritonitis, and it could also mean an internal GI bleed. So another complication is hemorrhaging, or basically bleeding. So key signs to look for is melena, that black stool, which is partly digested blood, described as black tarry stool, and even hematemesis, vomiting blood. Another complication mentioned by Hesse is gastric outlet obstruction. Basically, we have a blockage of the pathway from the stomach and into the small intestine. So Hesse mentions, which complication does the nurse monitor for while assessing a patient with PUD? Select all that apply. So they're all here. Perforation, hemorrhage, gastric outlet obstruction, and hematemesis, and melena. Now, diagnostics include an EGD. As mentioned earlier in the Gerd section, a scope is inserted via the mouth to look at the GI tract here. Now, a big NCLEX tip here. Any tube inserted into the patient's GI tract, this can perforate the bowel, or basically pop a hole inside the intestine. So perforation will lead to peritonitis and sepsis. And the big key priority to report to the HCP is fever. Now, another diagnostic procedure is an upper GI series with barium contrast. Clients will drink this chalky white substance that sort of acts like a highlighter in the upper GI, and then an X-ray is taken. This is done to diagnose abnormalities like tumors and even ulcers, as well as inflammatory conditions. So we must educate the client here, so write this down. NPO, no eating or drinking, and no smoking, 8 hours before the procedure, since both increase gastric secretions as well as motility, and it can alter the test, including smoking here. Now, expected during the procedure is abdominal cramping. Remember, this is normal and to be expected. And after is chalky white stool, since all that white chalky contrast is coming out of the body and into the potty. So when clients are being discharged or going home, we teach them to increase fluids to wash out that nasty contrast. So to flush the contrast, again, increase fluid intake, as mentioned by Kaplan, and take laxatives. Yes, take laxatives. Do not avoid laxatives. Put it on a t-shirt, write it on a bumper sticker. Don't avoid laxatives. 70% of students get this wrong. Remember, we want to flush out the barium out of the body and into the potty. Now, for causes and risk factors of peptic ulcers, the most tested are H. pylori bacteria inside the gut, and NSAIDs are non-steroidal anti-inflammatory drugs. Technically used long-term, this can reduce protective prostaglandins inside the gut, leading to a peptic ulcer. So write these down: naproxen, indomethacin, as well as ibuprofen. Those are the top 3 most common NSAIDs on the NCLEX and exit exams. Now, lastly, not a direct cause, but stress can actually prolong the ulcer. So stress like nursing school and even the NCLEX. So just watch yourself and don't get an ulcer here. Now for pharmacology, we can use antibiotics to kill that H. pylori bacteria. So we can use amoxicillin, but watch out for the allergies here. Xylins and cephs, or penicillins and cephalosporins, have a cross-sensitivity here. We can also use clarithromycin, tetracycline, metronidazole, and lastly, not an antibiotic, but bismuth is Pepto-Bismol. This guy coats the stomach to help with the pain. So Hesse mentions, a patient is diagnosed with H. pylori peptic ulcer disease. The nurse anticipates administering which drugs? Bismuth, tetracycline, and metronidazole. Now for acid reducers, we can use antacids, histamine receptor blockers, or H2 blockers. These guys end in tidine, like ranitidine. And PPI are proton pump inhibitors. They end in prazole, like omeprazole. These were mentioned in our Gerd section. But really the most tested drugs for PUD are mucosal protectants, like sucralfate and misoprostol. So Hesse mentions, which classes of drugs are used to reduce the symptoms of peptic ulcers? Select all that apply. So our acid reducers, antacids, are mucosal healing agents, like sucralfate, proton pump inhibitors, and histamine receptor blockers. Now, I know that's a lot to remember, so to make it super simple, let's play a segment from our pharmacology master course here. Now, for mucosal protectants, we have 2 here. So first up is sucralfate. Brand name is Carafate, given to treat and prevent both stomach and duodenal or duodenal ulcers in the small intestine. Now, the mode of action. It forms a thick protective layer over the ulcer, which provides a physical barrier against the stomach acids and enzymes. So it's kind of like a Band-Aid over an open wound. Or you can think it's like filling a pothole in the road. Now guys, the big key point here is we take on an empty stomach 1 to 2 hours before or after food or meds. So guys, do not take with any other med. And don't be tricked. Questions ask a lot about taking antacids with this med. Guys, we're avoiding anything and everything. So just think sucralfate 2 hours before or after you ate. And it's best at bedtime. So just think sucralfate, it's better taken late. Now for patient education, just like Gerd, we want to avoid foods that cause more acid. So for diet, we want to avoid spicy, fatty, fried, and even acidic foods. So the big no-no list: no caffeine like coffee, soda, or tea, no alcohol, and no cigarettes. Avoid that tobacco. Next, we want to de-stress here. So take a vacation or go to the beach, or maybe take an NCLEX study break. Next is avoid NSAIDs without a prescription. So no naproxen, indomethacin, and even ibuprofen. And we always report black tarry stool to the HCP, that melena. Remember, black tarry stool typically means we have a GI bleed. So a common NCLEX question: the nurse is educating a client on peptic ulcer prevention. Which statement by the client shows correct understanding? Select all that apply. So option 1, I will not drink beer at the party this weekend. No, that's incorrect. Always drink beer. I'm just kidding. Yes, no alcohol. Remember, on the NCLEX, alcohol is rarely ever good. Number 2, I will avoid using naproxen. Yes, avoid NSAIDs. Number 3, I should avoid drinking excess coffee or soda. Yes, caffeine in coffee and soda will cause more pain. Option 4, I will start smoking cessation. Yes, no cigarettes, and trying to stop smoking is best. And option 5, I will avoid spicy foods. Yes, but fried chicken is okay. No, we have to avoid both spicy and fatty foods like fried chicken or really anything fried with too much grease. Now, in terms of surgeries, not typically highly tested, but maybe just a nice to know. We can use a vagotomy where we cut the vagus nerve connection to reduce the rate of gastric secretions. Or we can use a pyloroplasty where a surgery is done to widen the opening in the lower part of the stomach in order to empty the stomach into the small intestine. Or we can do a gastric resection where we basically cut a section out of the gastric area, or basically the stomach. Again, not highly tested, but all these can cause a huge complication called dumping syndrome, where underprocessed food is dumped from the stomach and into the intestine, causing loads of problems, which we cover in a separate video. So be sure to watch that one. There's a lot of NCLEX tips in there. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the